when we talk about philosophy of utility, greatest good to greatest number of people is what we talk about when we give ART. Efficiency is minimizing the use of resources needed to produce an objective or maximizing the total impact is very important. Principle of fairness is what we talk about. And simplified guidelines have made it possible to treat an increasing number of patients with HIV within the community. Usually, HIV was one place where people affected with the disease came to become important part in deciding treatment. See, you have diabetics, but diabetics do not tell what is the treatment they would like to have. You do not have diabetics association fighting for, we want this treatment, that treatment. But in HIV, people living with HIV and AIDS become very important because it's a disease which is behaviorally transmitted. Okay, and they're necessary for upgradation of ART scale up. They sort of generate demand for testing, promoting adherence, and preventing the future transmission of HIV. This is why PLHS are being used for all this. Now this is a question, since this is a lifelong treatment and the amount of money that is available in the community or the government is limited, we cannot, should we start treatment or not start treatment because we are not sure that it can be continued. This is an ethical question. You start treatment today, tomorrow he has no money, then he will be worse off than not starting treatment itself. Sustainability is a question. We treat the patients even when we do not know what is going to happen in the future because we are thinking a now and here principle. Okay, now and here we know that we can treat. What happens in the future, we will see when it comes. We'll cross the bridge as we come to. This is the ethical principle that we apply and we start treating patients. Now, next thing that we talk about is it acceptable to charge patients for ART? See, this is in relation, what I am trying to talk about this is what the World Bank is trying to do to healthcare systems in the world. Now, you have user fees. Now, Karnataka had user fees, even in government hospitals, depending upon your income, you have to pay certain amount. Okay. So now the question is, should we do that for ART also? When you use the utilitarian principle, maximum good for the greatest good to the greatest number of people, the ability fair for when patients pay for that, there may be some amount of money which can be used to put more patients on treatment. Okay. But the problem is the social problem that comes with this. For many people, even that low charge for drugs creates an insurmountable barrier for commencement of treatment. And if patients may discontinue the treatment even if they cannot afford that low charge that takes place. So now that is why when you look at ART treatments, most of the places, even though it is WHO supported, I am not talking only of India, is always free for the patients in the government sector training. Now here is Mr. Anand, who has been diagnosed to have pulmonary TB. He has defaulted on medications twice. He has completed his treatment and is directed to be declared to be free from pulmonary TB. He is HIV positive. He has a sponsor who has agreed to provide him with money for the drugs. What will you do? See, it's been treatment for TB is 6 months. Okay, and it's only 3 drugs, once a day dosing. In that type of situation, he has defaulted twice. ART is much more complicated than that. It's a lifelong treatment. Will you give him treatment or not give him treatment?
No.
So this is an eternal debate that goes on. We'll go through some more cases before we come to a conclusion. Francis is an alcoholic, HIV positive, traveling salesman. He is eligible to receive heart based on his CD4 count. Will you prescribe treatment for it? He's an alcoholic, so he'll forget to take drugs. He has to travel.
There is no evidence that he has defaulted on taking the medications. So
No, but you know, no.
He's an alcoholic.
Alcoholics will forget.
In case of HIV, we have patients who are living without drugs for many years. So in cases like this, if they default the treatment what we are giving, the effect will be more than what will happen if the treatment is not started.
Okay. He wants to say something.
Yes, I think that he should be given treatment. But the only thing is that I think there will be a problem with him because he is an alcoholic and he can forget to go for treatment. And at the same time, he's a traveling man. He may decide to come today. Tomorrow he will not be there because he will be in another town. That's one side.
Yes. The point that this says there is, no, what I am trying to say is it's not just writing the prescription. You need to think of the other things that goes on. Here, this person does not have societal support, I mean family support. If he is traveling outside, nobody is there to remind him to take his tablets, unless his wife calls him on the phone and says, have you taken your tablet twice a day? Okay. These are practical problems that we face when we deal with treatment. And remember, adherence is the most single important determinant of clinical outcome. So, we need to support all patients to have better adherence. Okay. Making presumptions about patients' inability to adhere to treatment and then denying them access to ART is ethically problematic, because denials based on unreliable predictions amount to unfair discrimination. Okay. This becomes a problem in ethics, and when patients are non-adherent, it is the most crying need that they need help from the medical faculty. Okay. So, you cannot dismiss them by saying they are non-adherent, so we will not treat them. Okay. Now, here is another one. Khan is HIV positive, his family is well to do, they insist on starting ART, what will you do? See, remember, it is not the family or the thing that matters, it is the individual patient that matters. So, that goes into what we talk of a component known as readiness to treatment. All people keep talking, but there are no guidelines which tell you when the person is ready to talk this thing. And usually when you say this readiness to treatment, sometimes it can be misused not to give treatment, saying this patient is not ready, so we will not give that, because there are no guidelines for this. Ramakrishna is on ART medication, he is working as a contractor, he pays for his own medication, patient has discontinued medication for 3 weeks due to non-availability of medicines. Will you tell him to continue the treatment or discontinue the treatment? Okay. I will not go into technical details. We will say what I am trying to illustrate is, it is not just the drugs, we must make it accessible and available. Okay. So, you have to take all this into consideration when we are talking about HIV treatment. Medicine for 1 month, as he could not afford it, he wants to restart the medication. Try this another patient that we talked about. Will you allow him to do it? Yes, definitely we will allow it. So, there is always what is known as, this is another one patient, Jane is well to do, is on ARV for past 1 year, he has been abusing alcohol, is irregular to follow up, is discontinued medications for varying periods of time ranging from 1 week to 6 weeks. The reason given is that he is bored of taking medications. Now, he comes with a request to you that he will be regular and wants to take ARV again. Will you give it to him? So, remember, there is something called forgiveness factor. We need to forgive our patients. Okay. Though we come into a paternalistic mold where the patient does not follow, you get upset, but here we need to forgive the patients. Okay. Then we talk about vulnerable sections of population which are affected by HIV and AIDS, and usually they are the children, the poor and the migrant laborers and women. And we need to take a pro-poor approach to enable the poor to gain access to treatment, make the process of selection of patients as egalitarian as possible. People who cannot afford ART should receive it free at the point of delivery that they have, and usually there are different principles that are applied depending upon the vulnerable group. Saubhagya has lost her husband, she is also found to be positive, her children were HIV negative, she has sent her children to free hostels. At present she is staying in a home for HIV infected mothers. She had an episode of cryptococcal meningitis, she is on maintenance therapy for the same. The organization is willing to provide ARV, will you give it to her? Okay, definitely you will give it to her because she needs our care. Okay. Now, when we talk about barriers to treatment in women, there is a whole lot of barriers that come across, starting from poverty to domestic violence. Okay, the whole lot of them get into it. Then when we talk about children, children less than 15 years will be provided treatment, and I just want to see these two cases to contrast how difficult it is to handle children with HIV. You know, everybody says children have to be taken care of, but nobody thinks of child as an individual. Okay, we know the hemophiliac, 10-year-old, he was found to be HIV positive about 4 years ago. His doctor has put him on medications for HIV infection since the last 2 months. He does not understand why he has to take bad tasting medicines every day. You know, it's quite hale and hearty, and a 10-year-old child, what will you understand? It is important. Or he has Swati, a 7-year-old girl, mother died when she was 1 year old. She has been taking care by her father and her auntie. She cannot understand why she has to take medications every day when she has no other problems. Okay? And adherence becomes a major issue when you are dealing with children. And politically it makes very grand sense to say that you are taking care of children with antiretroviral drugs. We have 50, Clinton Foundation says we will give medicines to all the children who are infected with HIV and AIDS. But they never talk about the problems that are associated with HIV, AIDS and children. Okay. Now, next we come to HIV and marriage. Okay. Supreme Court, I will again come to this at the end when we talk about legal cases. Supreme Court decided that marriage is a physical, psychological and social union of two souls that they become one, and it is a very basis of the society. And now the question is it a human right? Okay, it is a human right. Is it a fundamental right? It is not a fundamental right, that is the point. See, when you say it is a fundamental right, it should be enshrined in the constitution, and if it is not enforced, you can go and sue the government. Okay, I cannot go and sue the government saying I am not married, get me married. Okay, it is a human right, definitely it is a human right. Okay, so this has to be very clear in mind when you talk about it. Now, I have put 2 cases here to talk about confidentiality and consent, which is important when you talked about the previous things. Divakar is HIV positive, he is unmarried, his parents have fixed his marriage in the village and his friends inform you a day before the marriage. What will you do? Okay. Now, I will give another one example. Ramakrishna is HIV positive, he has not told his wife, he says that he is practicing safe sex with her from time of diagnosis. What will you do? Will you tell his wife? Now, the ethical stand is uninfected persons have a right not to be infected or to be protected against infection. Okay. The legal stand is, the first point is changed. I have just kept it because this is to provoke little thinking. Infected persons have no right to marry. HIV can be a valid reason for divorce. Right to confidentiality is lost if another person's life is in danger. Okay. Now, when we come to NACO policy, okay, this is all the sections under which sexually transmitted diseases or a communicable disease is a reason for divorce. It is there in every Indian marriage act, whether it is Muslim Act, Parsi Act, Hindu Act or a Christian Act or a Special Marriage Act, you can give divorce if it is a venereal disease or a communicable disease. Okay. Now, the NACO guidelines say the physician has to inform the sexual partner of HIV infected person of the status. Okay. Now, how do we go about it? Is a question. Remember, all practicing doctors do not have free time. They are only interested in seeing patients and sending patients, and they are not much concerned about the social things. But the NACO guideline says that it is the duty of the doctor to inform the sexual partner. So, in practice what happens is we get 3 types of patients. One is the patient tells the partner and brings the partner for counseling. This is less than 10%. Okay. The second one that happens is patient asks the doctor to tell the spouse. This usually takes about 3 to 4 months or 5 months of talking to counseling. Then he says, okay, you tell my wife, or he is so moribund that he cannot make decisions, then you have to tell the wife. Okay. The third one, which constitutes of 40% of patients, is where patient does not bring the spouse at all. Okay. And we do not have any mechanism to go back to his family and trace and bring about this. The minute you do this, the patient will stop coming for this thing. This is an ethical dilemma that we face day in and day out. Okay. And Australian court held a failure of counseling when the patient underwent a marriage, even when he was HIV positive, knew about it, and its negligence and awarded damages. Okay. Now, this is a question, can a patient deliberately infect another person be punished? There is a Indian Penal Code 270 which says any malignant act likely to spread infectious disease dangerous to life. Whoever malignantly does any act which is and which he knows or has reason to believe likely to spread the infection of any disease dangerous to life shall be punished with imprisonment of either description for a term which may extend up to 2 years, or with a fine, or with both. Okay. So, there is a provision, it needs to be applied. The first place that is going to happen is that in Bombay, where 2 of the HIV infected wives have sued their husbands, I mean given police complaints to the husband, but the court has not yet decided what is going to happen in it. Can a doctor be sued or punished for not informing? The thing is, in section 269 of the Indian Penal Code says that when you have negligent act likely to spread infectious disease, and if you do not do that, you can get 6 months imprisonment or fine, or both. So, it all requires a police officer to catch a doctor and say you have not informed HIV and take a case, then you will have a case to come up with. Okay. Now, we come to a question of research. Now, when we talk about research, there are different research that takes place in context to HIV. One is the social sciences research, which I will just touch with. Much more important for as a medical person and clinical ethics is research that involves drugs, research that involves vaccines and microbicides. When we talk about research allocation, usually we have 2 groups. One group gets the active drug, another group gets an inactive drug. Now, the question is, after the treatment is over, should the patients know which group they belong to, whether they were in the treatment group or they were in the allocation group. And usually they have a moral right to know about that, though we do not do that. A study in BMJ showed that 50% of participants receiving placebo are informed about their treatment allocation. Okay. Then post-trial intervention is very important. See, the reason why we talk about post-trial intervention is, like I will give an example. If a patient is in stroke and you give the patient a drug, like you give him an anticoagulant. Okay. As long as the period of treatment is there with an anticoagulant, patient on the test drug, the company will pay for it. The minute the trial is over, we can always shift to a different anticoagulant and the patient will not suffer from it. Okay. But it is not so with HIV medication. If you start on an antiretroviral drug, you just cannot switch from one to another. He has to continue for it. So, there is a big question is what happens post trial in to the patients that happen in that. Okay. And usually most of the trials that take place nowadays make a provision for the participants to receive the drugs as long as the drug is not available in the market. But once it is available in the market, the patient may not be able to afford to buy that. So, this is a dilemma which the researchers have to face day in and day out when you do trials with HIV drugs. Now, the other thing that happens is paradoxical reactions. Okay. Now, what happens is you have monitoring of the drug as results every 6 months or 1 year, depending upon the sample size and the type of study that you do. And whenever you find that the treatment arm does much better than the control arm, you stop the control arm and convert the whole trial into treatment arm, and treatment becomes the standard of care. Like for example, Zidovudine, when it was used in prevention of mother to child transmission in 1994, it was so effective they stopped it. But that Zidovudine was starting from 16th week of pregnancy up to delivery time. You give IV Zidovudine and then you give 6 weeks for the baby, which was a huge amount of money. Okay, because it was so good, they stopped the trial. Then we had to find out whether shorter courses of Zidovudine prevent the transmission of mother to child, and this brought about it. Similarly, if you have adverse reactions taking place, which we will totally miss because we do not know whether it is because of the drug or because of the natural course of the disease, because the control arm is lost in this. And there is an ethical responsibility to see that drugs the affected patients get are also given into the community. Okay, this is an important thing, and usually it is difficult to apply it. And usually who should provide the intervention? This is another big problem. See, as long as the drug trial is there, the person who is responsible for the drug, whether the drug company or the researcher, will be responsible. After that, what happens? And ultimately the whole burden of providing the treatment will fall on to the healthcare systems to support it. Okay. So, when as researchers, when we talk about this, or is sitting in IRB, this is a question that you should always ask whenever a drug trial comes, especially with HIV medications. What is going to happen after the drug trial gets over? Because you cannot just shift drugs from one class to another class in HIV treatment. Okay. Residual damages interventions, usually there is a built-in mechanism in the protocol to take care of them. So, that is not something that we talk about. Then when the trial is over, what happens? This is much more relevant in underdeveloped or developing nations. You may have a sophisticated equipment, it will be operated by someone else, and when that person goes off, nobody will know how to use it, or the reagents may not be available. So, as IRBs, we must look into it, what happens to this equipment when the trial gets over. Now, vaccine trials is another important area, and we have 2 trials going on in India about vaccines, and usually patients may develop antibodies to the virus, and this is detected by ELISA. So, if that person does not reveal that he has been in a vaccine trial, he will be falsely accused of being HIV positive, and they may have other problems because of this HIV thing. And these issues must be discussed with the participants as part of informed consent. Those who develop antibodies can be given a slip which says that they have participated in this trial, and that is why their antibodies are positive. Okay. Now, the other problem that happens is phase 1 trials is okay. When it comes to phase 2 trials, there are much more ethical dilemmas that arise. You require a group of people who are sexually active, who have multiple sex partners, who will not use condoms, on whom you will give the vaccine to see what is the effect. That is the scientific way of doing it. Now, the ethical question is, how can you counsel a person, say, okay, you take this vaccine, you go about having multiple sex partners, there is always a risk, but we know this vaccine may protect you. These are ethical dilemmas that arise when we deal with the vaccine trials. Now, other thing that happens is unlinked anonymous testing that goes on for community surveys. In our country, the way the HIV the statistics is collected is by doing unlinked anonymous surveys, which starts from the month of August till month of October. Every blood sample that is tested by antenatal mothers in the government hospitals, a sample is tested for HIV, and that is how we project the HIV figures for it. STD clinics, high risk behavior clinics are STD clinics, truck drivers are this thing, and sex workers. Low risk is antenatal mothers. From this computation of this, the figures are raised for the country to see what is the prevalence rates that happen with HIV. Now, the ethical issue is, if you find somebody is positive there, don't we have a duty to inform that person? No. And here the way the ethicists escape from this question is, we are not worried about the individual, we are worried about the burden in the community. So, the benefits of knowing what is the prevalence in the community gets translated, and because there is more intervention, because there is a high prevalence state, those people will come to for testing. It is a circular argument that is given for unlinked anonymous testing that goes on. Next point that you would like to talk about is, whenever we deal with it, we must deal not only with our mind, but with our hearts also. When you sit in IRB boards, remember, when there is an ethical trial that comes, it is not only the scientific rigor, you have to take into account the social and the other implications that go with the trial. Okay. Now, we come to some of the prevention problems that we have. Okay. Is it a crime to do sex work? Okay. Indian Penal Code says it is not a crime to do sex work, but the crime is that you solicit for sex. Okay. If you come in a house, if you have sex and you get paid for it, it is not a crime. But you stand on the street corner, attract clients to come to to have sex with you, it becomes a crime. Okay. If a place is used as a brothel, it becomes a crime. Okay. Sex work is not condemned, but the things that go with sex work is condemned by the Indian Penal Code, and that is why people want to decriminalize it and make it by modifying the Prevention of Immoral Traffic Act. Okay. And it is in the draft stage, and the sex workers are protesting against it because it will cut directly into their livelihood. Okay. Now, it is this thing. And when we talk about sex work, you have different categories of sex work that goes on. This is based on studies from Tamil Nadu. You have brothel based, you have home based, part time, street based, call girls, and women work in variety of locations and have different levels of independence or restrictions accordingly. Sex workers reported that they see on an average 3 clients a day, although some studies say that they have 10 to 12 clients per day. Okay, so the truth is somewhere in between this. Okay. The point that is this thing is clients of the sex workers, you will see that it is quite a huge amount. 29% of men have paid for sex at some part of point in time in their lifetime. One common feature observed that is the studies is that men often go to sex workers in groups. Okay. And this happens especially when, because Bangalore gets quite a lot of people come from Andhra and from Tamil Nadu. It is very prevalent in Andhra Pradesh, where groups of people before marriage go with the groom to have sex. Here what happens is, the problem comes is in the sex work, and the ethical thing that we talk about is, if you remember, United States for all its HIV funding makes it mandatory that there will be anti-prostitution, anti-trafficking pledge will be taken by the organizations. Okay. But in reality what has happened is, whenever we have empowered the women sex workers to unionize, to fight for their rights, then the incidence of HIV comes down and the incidence of safe sex increases in the community. Okay. Then when you talk about men having sex with men, this again from Tamil Nadu data, where 2% of factory workers, 5% of truckers and 12% of young men in slums have this thing. And the important thing that they have found is, as compared to the West, is many of these men having sex with men are married. They meet the sex partners in covert and discreet surroundings, and IPC makes this a crime. Indian Penal Code Article 377 makes this a crime. We will talk about it when we talk about the cases that are present on that. Now, mandatory pre-employment screening for armed forces is done because the reasons that I have given us, they are in a very important position. They have to be fit all the time. They cannot come back and say that I am sick, I cannot go. They should be ready to deploy at any time. That is one reason. And second thing is, in a battlefield condition, many of the soldiers go and donate blood, and there is not time for checking for HIV status at that time. That is why they make it mandatory in the armed forces before the patients are taken up for, before the persons are taken into the army. Okay. Now, intravenous drug abusers, we have de-addiction centers, needle syringe exchange programs, and oral substitution maintenance by drugs can be used. Do these programs contravene legal provisions and drug treaties? So, if you have an intravenous drug abuser, will you go and complain to the police? Now, these are ethical issues that you have to handle, because you are dealing with this. Similarly, if you have a needle exchange program, it means you know that this person is committing a crime, you are helping him to commit a crime in a better way by providing needle exchange programs. And because of these reasons, United States does not have a needle exchange program. Okay. But the UNAIDS says helping IV drug users with needle exchange programs is consistent with the international treaties that are there for helping and prevention of intravenous drug users. Okay. Now, we come to another important is, condom promotion lead to increased sexual activity. This is a question that is being debated in the parliament. Sex education is creating increased sexual activity, but studies show that sexual education or condom promotion does not increase sexual activity, and on sex workers, even with the explicit information, does not increase sexual activity. What studies have shown is, in casual sex, using a condom as socially acceptable, enjoyable and safe might increase sexual risk behavior in people. Okay. So, there is always a chance that people may be complacent, saying that they have used condoms, so they need not be infected. Similarly, when we talk about the individual, using condoms also gives lot of problems for them. It is a visible thing, there is lack of trust between the couple, interrupts a spontaneous act, makes sex an impersonal act, acts as a barrier to spontaneity. Now, I will come to the court cases. Okay. Now, the court cases are divided, I have divided the court cases into different things. One is in relation to blood safety. This is medical negligence. The case was, first case that came about was in 2000 in Calcutta, where a woman was given contaminated blood and she turned out to be HIV positive, and the court gave her a compensation of 10 lakhs, provided her a job in Calcutta and took care of her treatment. The Indian Navy had to take care of it. The second one was from Tamil Nadu, where a blood bank gave a unit of blood and that blood was transfused without testing onto the patient, and the patient was offered 4 lakhs as a compensation with interest by the Supreme Court. The second group of cases are in relation to confidentiality. Now, this is a very interesting case which you have to talk about. This is happened in again from Chennai. This is a person, this is Dr. X, who was a personal physician to one of the ministers from Northeast. I think he is from Nagaland. He came down to Chennai Apollo hospitals for surgery, and when he went for surgery, the minister was very particular that he wanted only his tribe blood to go into him. So, the doctor donated it. When the blood transfusion was given, it was someone else's blood that was donated. So, the minister was upset. The hospital told him that the blood of your physician is contaminated with HIV. This is what happened, and this man was supposed to be engaged to get married to his, he went and broke the marriage because of some other reason. The minister went back, called his fiancée and told her that this man is HIV positive, don't marry him. So, he sued the hospital for breach of confidentiality. Okay, so, when this court went into the Supreme Court in the first time, this was heard by a single bench, and the single bench, this is when the Supreme Court said marriage is a covenant, it is much more than a contract, and it also said HIV is fatal and the spouse has to be saved, right to privacy of the patient is lost. It also said as a corollary, HIV positive patients cannot marry. You know, this is the thing that they talked about. So, this case was appealed to, and in 2002 again this case was reviewed and they came to a conclusion. The Supreme Court said what the court has talked about marriage does not stand, because it was not the contention of the case, okay, but it upheld the Apollo hospital breaking confidentiality. Okay. As a result of this, the second case, which was 2 HIV positive people asking permission to get married, was granted by the Supreme Court. So, today HIV positive people can marry. They have to inform their status. 2 HIV positive people can marry. HIV positive man or a woman can marry if it is a non-HIV person, provided they inform them about their marriage, about their HIV status. Now, we have a whole lot of judgments which are in favor of not discriminating HIV infected patients in relation to employment. Okay. They are all there. There are 2 cases that I have put classical cases. The first one is what talked about it. The Supreme Court, the Bombay High Court for the first time used initials instead of calling the person's name for it. And they said no person could be deprived of his or her livelihood except by procedure established by law, and that procedure must be just, fair and reasonable. So, if you want to dismiss an employee, you cannot just dismiss him because he is HIV positive. You have to have an inquiry, and the inquiry should prove that this person has not done his job, he is late for work, he is not coming regularly on time, and it is go to the due process, only then you can describe. And it held that if a person is fit to perform job functions, is otherwise qualified, does not possess a substantial risk to fellow workers, a government public sector cannot deny him employment because he is HIV positive. Okay. So, all the cases have gone through this stage. Now, the second point that we have this case is just to highlight how the courts are so well reasoned out. Here what happened is a Navy person, he was working in the submarine, he was found to be HIV positive and he had pulmonary tuberculosis. So, they boarded him out and put him on shore duty. Now, once you are on shore duty, your privileges and money comes down, because you do not get special allowances for going inside the submarine. After that, when this post fell vacant again, he again appealed saying that I want to go, and the commandant of the Navy refused to give permission. So, he went into the court, and the court upheld the commandant's thing, saying that it is necessary that this person should not go into the thing because it is a risk to the society. In a submarine, it is a closed thing. If this fellow gets infected with any other organisms, there is no treatment available. If he develops tuberculosis, he can spread the infection inside the thing. So, it is not that if it is HIV positive means nothing can be done. There is, depending on the situation, you have to take action. Okay. Then we talk about public interest litigation for litigations. NAS Foundation was what they talked about homosexuality to remove the section. The High Court removed, did not entertain it because saying that you have not been prosecuted, why do you want to fight for someone who is not involved, he is not before the court. But the Supreme Court asked the High Court again to reconsider the situation and test on this judgment. The second one is in relation to dance bars in Mumbai. Here people said our occupation is lost, we have lost livelihood, so we need to go back and get permission. The Supreme Court was very clear. It said dance bars, girls can work in the dance bar, but they cannot dance. So, there is no question of losing your livelihood. That is the argument. The dance bars, dancing is a small part of that bar. There are so many other work which you people can still do, so it cannot be allowed. And it also not only it reprimanded the government also for doing certain provisions on this, how you can allow dance bars in 3-star hotels, not in dabas. Okay, which again is not the due process of law, and Maharashtra government has gone and appeal against this. Okay. Then there is another one thing which is called by an organization called Sankalp, which is not yet decided. They are appealing, saying that the government should do everything for HIV positive patients. Okay, this case is still going on in the court. Okay, then there is an important thing in quackery. People who are from Kerala will be very familiar with Majid. Majid was a chemical engineer who became in the beginning as a homeopath, then he became a naturopath, and he produces a drug called Immunoq, and there has been lot of claims on it, and we know that it is a bogus drug. So, the Kerala drugs controller did not give permission for manufacture of this drug. Majid went in appeal against the Kerala High Court. Kerala High Court allowed him to manufacture the drug. Then the positive people went to the Supreme Court with a special leave petition asking that drug should not be manufactured. The Supreme Court again asked the Kerala High Court to enforce that the drug is not manufactured, and the Kerala High Court has to decide whether it is effective or not effective, and then allow its manufacture or not allow its manufacture. That is the last thing that I talk about. This is the HIV bill of 2007, okay, and this document is ideal. Okay. It talks about every possible situation, but how much of it is going to be implemented, I do not know. It when emphasizes there will be a HIV authority in India who will decide on problems that arise because of discrimination, stigma and all these things. So, they will be the major thing that they will be handling. So, it is still tabled on the parliament. So, we do not know how many of these provisions will be carried, but it is a very well detailed textbook like laws that are done for protecting the people. But the problem with that is it only looks from the HIV positive people. It does not take into account the problems the medical fraternity will have when implementing this thing. I think this is the last slide. I shall stop here. Any questions?
This is regarding the opt-out in the PPT-CT program. Yes, the government is very happy that more than 90% are coming into it, but I will raise a question. We can divide the women who are coming into this service into 3 groups. The first group, they counsel as a group or individual, they agree readily. The second group of women, they are hesitant to undergo that, and there is a negotiation or some sort of counseling going on, and in that process, it is implicitly told to them that if you don't do this, probably the doctor will not see you, because this is a process. A patient cannot go directly to the doctor. She has to pass through the counseling center and this and that according to NACO policy. Yeah. And third group of women, they again refuse to go for this, and they go to the doctor again. The counselor sends to the doctor, and doctor counsel this and that, and some of them agree to do the test, and some of them again, very few of them of course, disagree, and they went out not doing this HIV test. In the second group, where there's some counseling process is going on, implicitly, that is what I said.
There is coercion in the second group.
Yeah.
Okay. That is not acceptable.
Yeah, this is one my question.
You can talk to the patient and tell her that is necessary for you. We are in a high prevalent state, so it is essential that we need to test you. But not using a threat. If you don't do this test, doctor will not see you, it's unethical, it's illegal.
Yeah, that is the usual practice.
Yeah.
And when we talk about 90% attendance and all, they did all the tests. But out of that, how many of them came to get the results?
Yes.
And out of them, that can be looked into and see whether that 90% is really 90% or not.
No, there is always a difference between the people who undertake testing, people who come for results, and people who actually take the this thing. Unfortunately, I just do not remember the figures, but there is a lot of difference between people who undertake testing and people who come for results and people who actually get the drugs. Now, there are many reasons for that.
Okay. The second one is not a question. I just put it for the members to think of it. There was a statement saying that the number of people living with HIV is much, much less than the number of people who are living on HIV. How ethical this statement is, I don't know.
That is more like in Northeast. Okay.
Section 377, the case filed by Ashok Kavi from Asra. So one strong argument from the other side is that homosexuality or same-sex behavior is not by choice. They say that it is there in your genes. So as a person equally qualified in medicine as well as in ethics, I would like to get your opinion on that.
Which see,
whether it is by nature or nurture, or both.
See, for anything to happen, I am talking about basic community medicine knowledge. Three things have to be there. There should be a genetics or the host factor, there should be an environment factor, and there should be an agent. All three have to be there only to this. How much of what contributes, how much of percentage to what disease is still not determined for many of the things. So it is like that. All three are necessary. You may have the genes, you must have an environment.